Good evening everyone. Today we'll discuss pediatric vaginal yolk sac tumor as per the ESTRO guidelines. How we'll diagnose the cases, basically for the diagnosis full clinical examinations including vaginoscopy under anesthesia will be recommended. You can see this is the vaginoscopy image. This is the vaginoscope has been introduced. This is the growth. Okay, you can see this is the growth, tumor growth. This is the normal. This is the cervix. You can see that this is cervix, and this is the tumor's growth. This is the vaginal fornixes. Here another pictures also. This is the tumor growth. This is the yolk sac tumors. Yolk sac tumor pediatric groups, that is vaginal yolk sac tumor. In the vaginoscopy is the recommendations for to diagnose under general anesthesia or to go for a clinical examination. Under anesthesia examination, under general anesthesia, you go for vaginoscopy. Okay, and next point is second point, biopsy of for histological confirmation. Very important statement is biopsy for histopathological examination is not mandatory. It is not mandatory for the diagnosis. Mandatory for the diagnosis. Not mandatory in the diagnosis in presence of, if in the presence of, if there will be high alpha protein level, if AF is raised, that means it is itself, because in pediatric age group there will be high alpha protein level, then biopsy is not mandatory. If it is raised, then biopsy is not mandatory in that cases. Okay, but it should be undertaken in the, if there will be morbidity risk is low. If morbidity risk is very low, then you can take for biopsy in that cases. Okay, and very young patients, very important, very young patients, like very young patients, that is less than 2 years, biopsy should always obtain for histological examinations due to the physiological. If it is a very young patients, this statement you have to remember, very controversial statement. If very young patients, if less than 2 years, then biopsy should always obtain. The third point, always obtained for histopathological examinations or confirmation of the diagnosis of yolk sac tumor, because you can see in the less than 2 years group, if baby ka jo pediatric age group less than 2 years, there will be a physiological high AF level. So if you check for alpha fetoprotein level, they have already raised alpha fetoprotein level. So in that cases, if there is very young patients, very young age group, that is less than 2 years, you have to go. Biopsy should always, very important, this you have to remember all the keyword in the questions. Always, if it is a less than 2 year, you go for a always biopsy. Less than 2 year, always go for a biopsy, because in that less than 2 years, the physiological high alpha fetoprotein will be high, physiological raise level will be high. Okay, next, the third point I told, the third point gone, then fourth point is a diagnosis. Initial tumor resection should always be avoided. Very important. You should not go for after diagnosis. You should not go for a tumor resections. Tumor resections should be always avoided. Tumor resection should be always avoided. Okay, as why you should go for a avoided tumor resections? Because young age you should not do this much high risk operation surgery. So you go for a chemotherapy, because you know the germ cell tumors, the germ cell tumor is highly chemosensitive. So in that case, if it is you at the diagnosis, initial tumor resection should be avoided, and you should go for a highly chemosensitive chemotherapy, because germ cell tumor is very chemosensitive. Okay, suppose you go for a biopsy. In the biopsy, you go for a histopathological examination, along with you have to go for a plus biopsy plus histopathological examination plus IHC marker. In that IHC analysis, what are the things you have to do? First things I have to do is the antibodies against your alpha fetoprotein level. Next is your PLAF, placental alkaline phosphatase, then glypican 3, and fourth is your cytokeratin. Okay, so biopsy, if you in case you go for a biopsy, then histopathological examinations plus IHC, histopathological biopsy plus SP plus IHC analysis include antibody against these 4: alpha fetoprotein, placental alkaline phosphatase, glypican 3, and cytokeratins. Very very important statement. Okay. If you are go for a neoadjuvant chemotherapy, the platinum based chemotherapy has to be given 3 to 5 point is 3 to 4 cycles. 4 cycles should be completed. Okay. Told when you go for a surgery, should be surgery reserved for those situations, like in those situations where still persistent disease. Suppose you are giving chemotherapy after neoadjuvant chemotherapy, if there will be persistent disease, then you should go for a surgical management. Then after this, how we will follow? The follow-up will be first 2 years every 3 month, what we will do? Ultrasound has to be done every 3 months, consisting alpha fetoprotein. You have to measure the alpha fetoprotein level and ultrasound pelvis. Then next 3 years, like during the third year, every 4 monthly you have to do, every 4 monthly you have to do alpha fetoprotein level and ultrasound pelvis. Then up to then 3rd to 5 years you have to do every 6 monthly alpha fetoprotein level and USG. During follow-up, if AFP or AFP raise, during follow-up, if AFP raise or ultrasound is suspicious, you go for a MRI. Next step is go for MRI, pelvis and vaginoscopy to look for any residual disease. Vaginoscopy to look for recurrence, MRI and okay. 8 point is there ovarian. If you are go for a radiotherapy, in case of radiotherapy or brachytherapy, prefer over EBRT to minimize long-term morbidity. Radiotherapy is individualized. Radiotherapy only indicated if no complete response achieved by chemotherapy plus organ sparing surgery. Then if you go for radiotherapy, you should remember, you should go for because young age ovarian transpositions has to be done. Very very important. Ovarian transposition has to be done. Very very important statement. So basically the pediatric vaginal yolk sac tumors, as go ESTROguideline, full clinical examination. You go for a vaginoscopy or under examination under anesthesia, biopsy. If it is a alpha fetoprotein level is raised, like if it is more than 2 years, very very important. If it is more than 2 years, then no need to go for a mandatory biopsy in that patients. If you already raised, or you can go, if it is morbidity is very low, then you can go for a biopsy. Third point is in very young patient, like less than 2 years. Remember the key word is 2 years. Biopsy should always obtain for HP, because you should remember that less than 2 years there will be a physiological high alpha fetoprotein level. This is the growth. Okay. Then the fourth point, tumor resection. Always try to, in the young age, because they are very very young age, should not go for a initial local therapy. Initial therapy should be in the local surgery should be avoided. Tumor resection should be avoided, because germ cell tumor is very highly chemosensitive. Then biopsy, if you are go for a biopsy, again along with biopsy you should go for a IHC analysis. In the IHC analysis you should send antibodies against alpha fetoprotein level and placental alkaline phosphatase, glypican 3 and cytokeratin. The fifth point, 3 to 4 chemocycle therapy, neoadjuvant chemotherapy. Surgery is reserved only for those kids after giving neoadjuvant chemotherapy for 3 to 4 cycle. If there will be persistent disease, in that case you go for a surgery. Okay, follow up how will do in the first 2 year, you have to every 3 months to do alpha fetoprotein and ultrasound pelvis. Then next on the third year you have to every 4 monthly alpha fetoprotein ultrasound, and 3 to 5 years you have to every 6 monthly alpha fetoprotein and ultrasound. Alpha fetoprotein increase, ultrasound is suspicious, go for MRI pelvis and vaginoscopy to look for recurrence. If go for radiotherapy, ovarian transposition is very very important, because young patient there will be a gonadotrophic, so you have to do ovarian transposition before the radiotherapy. Thank you. If you like this, please subscribe and like.